For the investigation of the abdomen, various radio imaging techniques are used, like X-ray, ultrasonography, CT scan, MRI. Even in the X-ray, it is a plain radiography, barium studies, etc. are used. Anteroposterior plain skiagram in supine position is a standard procedure to investigate the abdominal pathologies. The anteroposterior plain skiagram is also known as the straight film, scout film, and KUB film. When it is done in acute condition, it is known as straight film. The scout film is obtained before taking a contrast radiograph, while KUB film is taken primarily for examining the kidney, ureter, and urinary bladder, for which the acronym KUB is used. As I mentioned, it is used for identify the gastrointestinal pathologies, urinary tract pathologies, or any abdominal conditions. Pregnancy is a relative contraindication for the X-ray of abdomen. In today's section, we will learn how to read X-ray film of abdominal region. These are the topics which we should consider while reading any X-ray film. It is that whether it is a plane or spatial, the view of the X-ray, posture, region, side, exposure and lucency, normal structures, visibles, other specific structures, and abnormality. We will discuss each one by one. Plane or spatial. If X-ray is taken without any spatial technique, then it is known as plain X-ray. As you can see, this image is taken without any spatial technique, while this X-ray is taken with the intravenous pyelography, which is a special technique. So this X-ray film is said a spatial radiograph. View of the X-ray film. As we know, in the anteroposterior view, X-rays comes from the anterior side of the patient and X-ray plate is put on the posterior side of the patient. In abdominal X-ray, when we take an anteroposterior view in supine position, the X-ray passes vertically. But when we take postero-anterior position, the X-ray will pass from posterior to anterior side. Here we can see three different images. In the first image, we can identify the posterior structures better. Like we can easily see in the spinous processes of the vertebrae. We can easily identify the posterior superior relaxed spine as well as the posterior. So this is the anteroposterior view. As we know that when the posterior structures are well visible, it is known as anteroposterior view. This is also known as the KUB view because it is used to image the kidney, ureter, and urinary bladder. As I mentioned previously, anteroposterior view is the standard view for abdominal X-ray. If anterior structures are well visible, then it is known as the posterior-anterior view, like in this image. The posterior-anterior view are rarely taken and it is almost obscured now. Sometimes we take a lateral view also to identify the position of the pathological structure or foreign body. Posture of the patient. Generally, abdominal X-rays are taken in supine position, as you can see in this image, and sometimes to investigate air in the peritoneal cavity, it is taken in erect or decubitus position. In supine position, the transverse colon is comparatively at lower level than the transverse colon in erect posture. As you can see in this image, the transverse colon has reached us almost up to L5 level, while in this image, the transverse colon has reached at L2 to L3 level. In erect posture, we can easily identify the air under the left diaphragm, while it is generally not seen in supine position. So this is the two basic criteria by which you can identify whether the X-ray has been taken in erect posture or the supine position. Sometimes, in some cases, when erect posture is not feasible or not give proper diagnosis, the lateral decubitus position is also given to the patient for the X-ray, as you can see in this image. Lateral decubitus position, here we can see the air under the abdominal wall, and this is the air in the large intestine. So we can see the air under the abdominal wall if the lateral decubitus position is given for the investigation of air in the peritoneal cavity. In abdominal X-ray, the diaphragm, lateral wall of the abdominal, and pubic symphysis should be visible. But as abdomen is quite large area, a single X-ray film may not cover the whole abdominal region. In that case, according to the investigating area, film are taken where some lower part or upper part may be left. As you can see here, we can see the whole pelvic region. So we can say this is the abdominal region and this is the pelvic region. The pelvic region is focused when our target organs are pelvic organs. Generally, side is mentioned on the X-ray in such letters like L. L indicates the left side of the X-ray. Some where R is written, they may mention the right side of the X-ray. If the side is not mentioned, the student should be able to identify the side of the X-ray based on the orientation of organs in the abdominal cavity, like ascending colon, splenic flexor, hepatic flexor, and cecum. The observer should hold the X-ray in such a manner that the right side of the X-ray remains on the left side of the observer and the left side of the X-ray should remain on the right side of the observer. In poorly exposed X-ray, the bony tissue or the soft tissue may not be differentiable. On the base of the Lucency, we can identify the structure like the air in the lung, stomach, and bowel creates a black colored shadow in X-ray film. As you can see here, this is the air in the fundus of the stomach. Here is the air in the lung, and this is the air in the large intestine. Dark gray color is because of the subcutaneous tissue. As we can see here, light gray color is by the soft tissue or fluid, solid organs like liver. It is because of the muscle also. Bowel wall also gives the light gray color. Fluid filled organs like urinary bladder and gallbladder also gives light gray color. While off-white color is given by the bones like ileum vertebrae. The bright white colors is produced by the contrast material, foreign bodies, surgical clips, artifacts, prostheses, etc. In previous lecture, we discussed how to read abdominal X-ray film, and we know that anteroposterior plane skiagram in supine position is the standard procedure, and anteroposterior plane skiagram is also known as the straight film, scout film, survey film, and KUB film. The abdominal plane skiagram is indicated for various gastrointestinal abnormality with various genitourinary abnormality as well as for suspected foreign bodies and in acute as well as chronic abdominal conditions. Pregnancy is the contraindication in abdominal X-ray. In emergency condition, no preparation is required, but for the better film, we require to prepare the patient. An object of preparation is to get the gastrointestinal tract devoid of any food material, any fecal material, or any type of gas. For that, we can give the patient antiplatelant like enzyme preparations, charcoal tablet, and laxative. Patient is kept nil by mouth for about 12 hours before the investigation. In case of constipation, the patient may given enema to empty bowel. This image shows the plain anteroposterior view of abdominal region taken in the supine position, where we can see the shadow of soft tissues and muscles, as well as we can see the opacity of bones. Let's try to identify various structures. Let's try to identify various structure in this image. This is the anterosuperior iliac spine. This is the anteroinferior iliac spine, head of the femur. Here we can also identify the inlet of the pelvis, the iliac crest. This is the posterior superior iliac spine, posterior inferior iliac spine. This is the sacroiliac joint. This indicates the ala of the sacrum. This is the sacrum, and this part is the coccyx. Here we can see the L5 vertebra, the spinous process of L5 vertebra, transverse process of L5 vertebra, intervertebral disc, L4, L3, L2, L1, and T12. This is the 12th thoracic vertebra, which articulates with the 12th rib. Just above the T12, this is the T11 vertebrae, which articulates with the 11th rib. So these things, these bony structures, we can identify in this image. In this image, we will try to identify various organs and structure. Organs gives a shadow in the abdominal X-ray. Here we can identify the lower border of the liver in the right upper quadrant of the X-ray. Here we can identify the spleen. This shadow is of the right kidney. This is the shadow of the left kidney. Generally, ureter are difficult to identify. For therefore, we have just drawn a dotted line for the ureter here. Here we can see another shadow. The shadow is by the psoas major muscle. And in the pelvic cavity, we can see this urinary bladder also. In this image, we will try to identify gastrointestinal organs. This is the image taken in the supine position. Here we can identify the stomach, and this is the cecum, ascending colon. Here is the hepatic flexor of the colon. You can identify the lower border of the liver here also. This is the transverse colon. This is the splenic flexor of the colon, descending colon, and this part is the rectum. This is the sigmoid colon. In this image, we will try to identify the loops of small intestine. As you can see here, large intestine covers the peripheral part of the abdominal cavity, and in the center part, we can identify this type of structure. This is the loop of the small intestine. You can see the air in the large intestine as well as at some time air in the small intestine is also visible. This is the focused and enlarged part of the large intestine where we can identify the circulations. The circulations are clearly visible in plain abdominal X-ray. In addition to the circulation, we can identify this thickened opaque white structure. This is the tinea coli. This is the splenic flexure of the colon. In some case, or in complications like intestinal obstruction, we can see the air fluid level in the colon, small intestine as well as the large intestine. Here is the image taken in the erect posture where we can see air fluid level. This is the air fluid level in the large intestine. Here also this is the air fluid level. This black is the air and this white part is the fluid. And between the air and fluid, here we can see the straight line that indicates the level of the fluid in a dilated intestine. You can identify thus multiple air fluid level in this X-ray because this X-ray is taken in the erect posture. Air is on the upside and fluid is on the lower side. Here is also the air fluid level. This is the air fluid level in the small intestine. This is the characteristic sign of intestinal obstruction. In addition, in the supine position, we can identify the dilated small intestinal loops. So the observer should be able to differentiate between the normal intestine and this type of dilated loops of the intestine with air fluid level. In normal abdominal X-ray, we can see a air in the fundus of the stomach, which is just below the left dome of diaphragm. It creates a black shadow and is known as the air under the left dome of diaphragm or air in the fundus of the stomach. It is a normal condition. This is the right dome of diaphragm and this is the left dome of diaphragm. In this X-ray, we can identify the right dome of diaphragm and left dome of diaphragm. This is the stomach and this is the air in the fundus of the stomach. But here we can see another air shadow between the fundus of stomach and dome of diaphragm. On the right side also we can see the black shadow between the upper margin of the liver and right dome of diaphragm. So this image indicates that air is present in the peritoneal cavity, and this condition is known as pneumoperitoneum. This X-ray is taken in erect posture. Sometimes we can see such type of calcified structure like this. This is the renal calculus. In some condition, the lower margin of the liver extend downwards. Although this may be the normal, but this extended lower margin of the liver is known as reader's slope. Plain abdominal X-ray like this. This is the plain anteroposterior view of an abdominal region showing the anterior superior iliac spine, anterior inferior iliac spine, iliac crest, posterior superior iliac spine, posterior inferior iliac spine, sacroiliac joint, head of the femur, sacrum, coccyx, as well as the vertebrae, 11th and 12th hips, and soft tissues like liver, spleen, kidney, psoas major muscle, large intestine, small intestine, without any visible abnormality. First is the intravenous pyelography, that is also known as descending pyelography. It is a radiological study of renal parenchyma, pelvic palatal system, ureter, and urinary bladder. Intravenous pyelography is generally done for structural and functional assessment of urinary system. It is contraindicated in case of non-renal failure and allergy of the dye. For the preparation of the patient is kept drill by mouth for 8 to 12 hours before the procedures. Laxatives are given. Serum creatinine is done to confirm the functioning kidney. Again, history is confirmed whether patient has any allergy of the drug or not. And patient is asked to empty the bladder before injecting the dye. Before injecting the dye, scout film is taken. After the scout image, a water-soluble non-ionic contrast known as urographin 60% or 76% or Conray 420 or Conray 280, which is selectively excreted by the kidneys, is slowly injected intravenously. We have to take care that the dye does not spill over the vein because it is quite irritant and may slough off the skin. Then skiagrams are taken at 1 minute and after that at the interval of the 5 minutes. Here we can see the first scout image of plain abdominal X-ray. This image shows the pelvic region. At 1 to 2 minutes after injecting the dye, we can see the shadow of the kidney because dye may have reached to the kidney. This image can be known as nephrogram. At 5 minutes, we can see the shadow of calluses. Calyces are cap-shaped structure. We can see the major calyces here. Funnel-shaped structure is the pelvis. This is the initiation of ureter. So this can be known as pelvico-ureteric junction. The same structures are visible on the another side. Ureter can be extended up to the urinary bladder. At 10 minutes, we can see the shadow of urinary bladder also. In addition to the ureter, pelvic-ureteric junction, renal pelvis, calyces, and kidney. At 25 to 30 minutes, we can see the complete urinary system from calyces to the urinary bladder. This is the image of pelvic region showing the urinary bladder. This is the lateral view. Lateral view is taken to confirm the position of pathological structure like renal stone. In this image, we can see the calyces, pelvis, and ureter on the right side of the patient. But at the same time, the calyces, pelvis, or ureter are not visible on the left side. In intravenous pyelography, to assess the function of the kidney, dye should appear at the collecting system at the same time, but we cannot see the dye on the left side at the same time. Instead, we can see a shadow of renal stone. This is the prevesical renal stone. Second is the retrograde pyelography. It is also known as ascending pyelography. Retrograde pyelography can assess only the structural pathology. It cannot assess the functional pathology of the kidney or urinary system. It is indicated when intravenous urography or CT scan urography cannot give proper result of the ureter segment. The preparation is the same as it is in the intravenous urography. For the procedure, before injecting the dye, a scout image is taken. Then cystoscope is passed through the urethra into the urinary bladder. Through the cystoscope, ureteric catheter is passed through the ureteric opening up to the renal pelvis. 5 to 10 milliliter of 6 to 8 percentage sodium iodide, dye known as Conray 280, is injected, which fills the renal pelvis. Once the renal pelvis are filled up to its capacity, it induces pain. At that time, we should stop injecting the dye and spot images are obtained of areas of interest. In the first image, we can see a catheter. That is the ureteric catheter which is passing through the ureter. Here, the image shows the dye injected through the ureteric catheter, which gives a shadow of the calyces and renal pelvis. In the third image, we can see ureter also in addition to the calyces and renal pelvis. So now we can read X-ray of palligraphy like this. This is a special X-ray taken by the intravenous palligraphy. It is an anteroposterior view where we can see the shadow of the kidney on both sides, renal calycis, pelvis, pelvic ureteric junction, ureter, and urinary bladder without any visible abnormality. For the retrograde palligraphy, this is a skiagram taken by a special technique known as retrograde palligraphy, where we can see the shadow of the calycis, pelvis, ureter on the right side without any visible abnormality. How we can differentiate the skiagram of intravenous palligraphy and retrograde palligraphy? In intravenous palligraphy, we can see the shadow of renal pelvis on both sides, while in retrograde palligraphy, we can see the shadow of pelvis only on one side. In addition, in retrograde palligraphy, we can see a catheter through which the dye is injected. This is how we can differentiate the skiagram of intravenous palligraphy and retrograde palligraphy. Department of Anatomy, Purdue Government Medical College, Rajkot welcomes you in the lecture series of X-ray abdomen. Today we are going to discuss about a special technique known as barium studies under headings of barium swallow, barium mill, and barium enema. Barium studies are generally performed to visualize and examine alimentary tract by using the suspension of barium sulfate in water. Barium sulfate is a chemical with a high molecular weight. That's why it gives a radio opaque shadow on the fluoroscope. It is non-toxic to the body. It is not absorbed in the gastrointestinal tract. It is not soluble in water and can make suspension or emulsion in water. Because of these characteristics, barium sulfate is used in barium studies. When barium passes through the lumen, it outlines the mucosal pattern that can be examined and radiographed. On the basis of this principle, we can have images for the gastrointestinal system and its lining wall. Barium swallow is generally used to evaluate the upper gastrointestinal tract like pharynx, esophagus, and stomach to identify various abnormalities or pathologies in the pharynx, esophagus, or the stomach. In this technique, we use 50% suspension of barium sulfate, which is swallowed by the patient 2 to 3 times standing behind the fluoroscopic screen, and images are taken when the patient swallows the barium sulfate solution. Here we have 2 images. First image shows the barium present in the pharynx. This indicates the shadow of the barium. This is the vallecula, and this part is the pariform sinuses. Second image shows the esophagus in the thoracic part. This is the outlining of esophagus. Because of the barium, we can see a radio opaque shadow. Esophagus passes through the diaphragm at this level and it enters in the abdominal area. In this image, we can identify esophageal sphincters. As you can see in the frontal view of the image, this is the trachea. At T4 level, it bifurcates into left bronchus and right bronchus. This is the arch of aorta. This is the clavicle. In the oblique view, we can identify the constriction due to arch of aorta and a constriction due to left bronchus. The fourth constriction is at the point where esophagus pierces the diaphragm. And the first constriction is at the initiation of the esophagus. These four constrictions are normal anatomical constrictions in esophagus. This is the frontal view of cervical part of esophagus in barium swallow technique, where we can see the esophagus from the pharynx to the lower part of the cervical. This is the lateral view. Here we can see the normal curvatures and structures of esophagus. This is the thoracic part of esophagus. This is the frontal view. Again, we can see the normal curvatures of esophagus. This is the lateral view where we can see the thoraco-abdominal diaphragm, the lower end of the esophagus, the esophageal foramen through the thoraco-abdominal diaphragm, and this is the gastroesophageal junction. And this shadow is the shadow of the stomach, where we can see the air in the fundus of stomach also. These are the several pathologies identified by barium swallow technique. In the first image, the lower part of the esophagus shows the bird beak appearance. It is also known as rat's tail appearance. This is the condition known as achalasia cardia. In the second image, we can see the dilated gastroesophageal junction. This condition is known as Barrett's esophagus. In the third image, we can see the constricted part of the esophagus. This is because of the right aortic arch. Barium mill is generally used to evaluate the small and large intestine. In barium mill, the patient is kept nil by mouth for 10 to 12 hours. Then on the day of procedures, 300 to 400 milliliter of the 5% barium sulfate suspension in water is given to the patient, and successive radiographs are taken. The sulfate medium reaches the ileocecal region in 3 to 4 hours. It reaches to the hepatic flexor in 6 hours, splenic flexor in about 9 hours, descending colon in 11 hours, sigmoid colon in 16 hours, and usually evacuated in 16 to 24 hours. These are the images of barium mill. When barium enters the stomach, it tends to form a triangular mass below the air of fundus. It then descends as a narrow stream to the pyloric part of the stomach. In addition, the shape, curvatures, peristaltic waves, and the rate of emptying of the stomach can also be studied. The beginning of the first part of the duodenum shows a well-formed duodenal cap produced by poorly developed circular folds of mucous membrane and protruding pylorus into it. The rest of the duodenum has a characteristic feathery or floccular appearance due to the presence of well-developed circular fold. The circular folds are also known as connivent valves. These connivent valves starts appearing after the duodenum, continues in the jejunum, and reduces in number as it goes towards the ileum. The greater part of the small intestine presents a feathery or floccular appearance because of the presence of transverse mucosal fold and their rapid movement. This is known as connivent valves. However, the terminal part of the ileum is comparatively without such type of mucosal folds and does not show a such type connivent valves. In this image, again, we can see the shadow of stomach, pyloric part, duodenal cap, second part of duodenum, third part of duodenum with connivent valves. Here is the duodenojejunal flexure. This is the loop of the jejunum, and this is the ileum. Our next technique is spadium enema. Generally, it is done to evaluate the large intestine. It can be done as single contrast method and double contrast method. Patient is given mild laxatives 2 nights before the examination, and plain water enema on the morning of the examination is given. Then 2 liters of barium sulfate suspension is introduced slowly through the anus till the barium starts filling the terminal ileum. Then fluoroscopic images are taken. Here we can see the first image where this is the transverse colon, this is the descending colon, and this is the ascending colon. This is the cecum, and this is the loop of intestine, small intestine. This image is taken before the barium enema study. Now we put the rectal tube in the rectum and start entering the barium sulfate solution. As the solution passes first through the rectum, then sigmoid colon, then it will pass through the descending colon, transverse colon, ascending colon, and will reach to the cecum. After passing the barium, we can have images of the large intestine. As you can see here, the first is the rectum, can be seen in the pelvic region. Then a dilated structure, a sigmoid colon. This is the descending colon. This part is the splenic flexure, transverse colon. Here is the hepatic flexure, and this is the ascending colon. This image is taken by the double contrast method. In the next image, we can identify the cecum, which is the lowermost part of the ascending colon. Here we have focused on the cecum part, where we can see the dilated part known as cecum. We can also identify the appendix, ileocecal junction, and terminal part of the ileum. In barium enema, we cannot see the whole small intestine, while in barium mill, we can see the small intestine. In barium enema, large intestine is visible. That is also visible in some barium meal studies. Here we can compare the barium enema and barium meal X-rays. As I mentioned, in barium enema, we can visualize only large intestine and small intestine generally does not appear in the barium enema studies. While in barium meal studies, we can see the small intestine, although large intestine may also be visible in barium meal studies. By these studies, we can identify any intestinal obstruction also. Here are some important interesting cases identified by the barium enema studies. In this image, you can see there is no smooth lining and absence of hostrations of the large intestine. This shows the granular appearance also. This is because of the ulcerative colitis. So the whole colon without skip is affected by an irregular mucosa with loss of normal hostration markings. In this image, we can see the small evagination from the large intestine. These are the diverticulosis. Hysterosalpingography is a radiological method by which the uterus and uterine tubes are visualized and their patency is confirmed. And the radiograph thus obtained is called a hysterosalpingogram. This procedure is performed to assess the uterine as well as the tubal morphology and patency, although it is contraindicated in non-pregnancy, acute pelvic infection, and recent uterine and tubal surgery. Hysterosalpingography is performed in initial 5 to 10 days of menstrual cycle where uterine wall is comparatively thin. After antiseptic cleaning of the external genitalia, the vaginal speculum is inserted. Then a catheterization of the cervix is done, preferably by 6 FR Follis catheter. The catheter should reach to the internal os of the cervix, and cannula is connected to a syringe through which the 5 to 10 milliliter of an iodized soluble contrast is injected under fluoroscopic guidance, and then skiagrams are taken. These are the schematic diagram where you can see the vaginal speculum and the cannula of the catheter here. This is the internal os of the cervix. This is the uterine cavity and this is the uterine tube. This is the lateral end of the uterine tube. Now, when the dye is injected, it will pass through this cannula into the uterine cavity. And because the dye is radio opaque and we are doing the procedure under fluoroscopic guidance, we will have images of this opaque dye that indicate the of the uterus. The dye passes through the uterus to the fallopian tube. The cavity of the fallopian tube is also catched in the fluoroscopic images. This is the video where you can see the dye injected through the cannula and that passes through the uterine tube. Again, we have repeated this video again. You can see the dye injected through this cannula. Yes, and this is the it passed through the uterine cavity and it passed through the fallopian tube. This is the cannula. This is the inferior pubic ramus and this is the obturator foramen. So this is the lower part and this is the upper part of the pelvic cavity. Now this is the image where you can identify the cannula as we saw in previous video. This is the vaginal speculum. We will inject dye here. This is the ala of the sacrum and this is the iliac crest. So this is the pelvic cavity. Okay. Here we will inject the dye. Let's see what happens. So we have injected the dye. Now you can see this small opaque shadow. This indicates a uterine cavity. This is the uterine cavity. Similarly, you can identify this thin white line on both sides. This thin white line indicates the cavity of uterine tube. This is the lateral end of the fallopian tube. Yeah. We have enlarged the image. Here you can see the uterine cavity. This is the cervix as well as the vagina, and this is the fallopian tube. This white line is the fallopian tube. I am drawing over the white line. This is the fallopian tube, and this is the lateral end of the fallopian tube. Similarly, you can see on this side also. Okay. Now, what happens if we inject further? We have injected further dye, so the dye has spilled out from the fallopian tube. So this indicates that the uterine cavity is patent as well as the fallopian tube is patent. Here the dye is spilled out in the peritoneal cavity. In some cases, like in this image, as you can see, this is the uterine cavity, but you can identify the uterine cavity is divided here. So this is a congenital anomaly known as bisected uterus. Similarly, in this image, you can see the shadow of the uterine cavity, shadow of the left fallopian tube here, where dye has passed through the left fallopian tube and spilled out in the peritoneal cavity, but the shadow of the right fallopian tube is absent. That means right fallopian tube may have blockage within it. So this condition is known as unilateral cornual block.